Mm. Hi, everyone. Thank you for your patience. And tonight we are on Facebook Live for an event that I am extremely excited about. I know it looks like I'm calm, but I am jumping up and down inside because we have a very special guest tonight. We're joined by Dean Michelle Williams. She is Dean of the Harvard T.H. Chan School of Public Health. I was there briefly when for a couple of years for a master's, and Michelle Williams was the chair of the epidemiology department at the time. And Dean, I didn't tell you this earlier, but I had the great pleasure of hearing you give a lecture in one of my classes on gender and public health. And at the time, you spoke about intimate partner violence and some research you had done on the issue. And I was really moved by, the severeness, the severity of the topic, of course, but also how you were able to communicate that in a very compassionate and human way, even though, epidemiology is a bunch of numbers. But at the end of the day, it's a very human problem. So I've been a great fan of yours ever since. So thank you very much for joining us.
Thank you. Thank you, Councilwoman. Mm-hmm. It's a pleasure to be here. Thanks for the invitation. And I'm so proud of what you're doing, using your education and leading in public service, especially during times of a pandemic. So thanks for your leadership.
Thank you very much. I think I mentioned this to you. I did not expect that this is where my public health degree was going to get me, but very glad for having that background that you and the rest of the faculty there provided to the group, to all the students there. So I have a few questions that we'll go through, and really the topic that we do want to get at is racism and public health. But before we jump into that, I'd like to ask you a little bit more about you so that our watchers, our viewers get to know you. So public health is a field that we don't hear much about growing up. It's not like being a doctor or a lawyer or a teacher. So what I'd like to know is about your personal journey into public health and what led you into that.
Yeah. Well, thank you for that question. And again, good evening, everyone. It's a pleasure to be here and to share. I'm an immigrant. I was born in the Caribbean, in Kingston, Jamaica, and my parents emigrated when I was 7. And, in our household, we were everything is about education. My family, my parents had less than 9 years of formal education between them. But you'd never know that because for them, everything we did from beginning to end and everything in between was around ensuring that we had the best opportunities and that we never cut corners on our education. And because of that, and I'm a product of public school education in New York. We emigrated to New York. And this was during the 70s and 80s. The 70s, had an opportunity to be lucky having good public school teachers who really looked out for talented students. And I ended up at Princeton, a wonderful liberal arts college focused on undergraduate education. And it wasn't until after I graduated from Princeton that I actually heard the word epidemiology and understood what public health is. And I fell in love because public health allowed me to exercise my two passions. One is biology. I'm a biologist at heart. I trained as an undergraduate in molecular biology, but in the lab alone wasn't soul-filling enough. As a 20-year-old still looking for ways to give back to the community that I came from, give back to the community that got me to university, I wanted to be engaged in social justice work. And public health happened to be that place where you could be both a biologist and a servant of public good.
Wow.
And that was my journey to public health. It was a chance finding, a chance discovery of public health in all places and the engineering department at Tufts University. Another lucky moment in my life. And that led me then to realize that I could do biology, I could do quantitative sciences in epidemiology, and I could attach that to a social justice framing through public health.
I want to tell my story too, but that's not why we're here.
I would love to hear your story. You should share your story. And the reason I think it's important is our journey to public health is a very interesting one because, public health is not well understood. I mean, I graduated from one of the best liberal arts universities in the land. I know you graduated from MIT. And our journey to public health oftentimes is by chance, by luck. And that shouldn't be. So tell your story, please.
Okay, I will for you, Dean Williams. The truth is, a lot of people who are watching this Facebook Live, I campaigned to them. I knocked on their door, and they know way too much about me. But I was also in a graduate program in civil and environmental engineering, like you, and ended up leaving that. And I was in a doctoral program at the time because the lab work was, I would say, it just wasn't fulfilling. I was by myself with a computer. As much as I like doing quantitative things, it didn't feel meaningful. I moved back home and I worked in the public sector where I found how government decisions can really affect day-to-day lives and opportunity for people. I also worked in air pollution control. That had been my graduate study. And after some time there, I realized the disconnect between air pollution control and how it really affected people's health. So people would come to us, to our public meetings and say, my nose is bleeding. This happened to my eyes. It's because of the asbestos that's happening in this construction project. And nobody on our staff could answer whether or not that was the case. There were certainly a lot of social justice issues tied up with that too. Who lives by the freeways, who lives by the port, what income levels are they at? And so I left my job and I went to study at HSPH, and I loved almost every minute of it. But I came back home wanting to serve and improve the health of the people here in San Antonio.
And that's really such an compelling story, because I always say that people come to public health with a full array, a full spectrum of why public health. But how we discover it is through a real searching process. And I'm so glad that we have this discipline that is designed to really understand the web, the causal social web that impacts health on scale. And in our studies, we try then to bring about solutions that also can be brought to scale and alleviate, adverse health situations for large populations at a time. So thanks for sharing that. I mean, public health for me gave me cause, gave me purpose, and gave me the language, the tools, and the template for having impact on scale.
And you have. So now I'm going to ask you a little bit about your work. And I know I saw you give a lecture on intimate partner violence, but your work is broad. It's extremely influential. Could you share a little bit of that with us?
Sure. For 20 years, I conducted my own research program, and I started primarily focusing on understanding the modifiable risk factors that contribute to adverse pregnancy outcomes. I started in biology and developmental genetics, and I took that interest in biology into the biology of healthy pregnancies and early childhood development. And so I spent a lot of years trying to understand why African-American women in particular had very high risks of adverse pregnancy outcomes, largely brought about by underlying medical complications like hypertension in pregnancy and gestational diabetes. And I thought if I studied the occurrence of these adverse outcomes using the best, absolute, most rigorous scientific methods, that I would build a knowledge base that you could then use to bring down the high disproportionate burden of adverse pregnancy outcomes in populations, all populations, but especially underrepresented minority populations. I continued that work for a lot of years. And then I realized that it wasn't so much the biomedical factors that were driving the adverse outcomes. There were the social factors, social determinants of health. And so I migrated away from just studying, the impact of omega-3 fatty acids, fish consumption in the diet, to why is it that women in pregnancy are not eating a healthy diet? Why is it in pregnancy women aren't engaged in physical activity? The wellness and health promotion activities we know are supported with are supportive of good health outcomes. And I moved upstream to social determinants. And that's when I started to realize that there was a high burden of untreated depression and anxiety among pregnant women of all ethnicities, race, and economic class. And that undergirding that high prevalence of mood and anxiety disorders were histories of social isolation, intimate partner violence, those social determinants, as well as the behavioral individual ones. And that got me to really understand and appreciate that a holistic approach in understanding the environmental contributors to health, the social determinants, are critically important. And I wove that into my research and into my advocacy.
That's fascinating. And I have so many follow-up questions on that, but I'll move on to, actually, I'll use what you said as a bridge. You started looking into how African American women had this had adverse childbirth or pregnancy experiences. I'm so nervous. I'm stumbling over my words. And so let's also talk about racism here. At what point, you issued, you sent us all, you regularly send us emails. Thank you for those to the alumni. And one of the recent ones was regarding George Floyd. And you said very clearly that racism is a public health crisis.
Yeah.
So I wonder, at what point in your career did you realize that? Or did you know that innately? So I just like to hear your thoughts on that.
Yeah, no, thank you for that question. And, it's a powerful one. And I'm going to answer two ways. First, personally, in my own upbringing, you get a sense, an inkling of inequality. I mean, in my immigrant family household, it was not uncommon for us to hear regularly from our parents that in America, to advance, if you're Black and brown, you have to work twice as much, twice as hard to get the recognition, to be even seen. And, I started to appreciate that very early in life, that, rewards don't come equally on the basis of your race or even where you're from, if you're an immigrant or not. So having that immigrant experience and being raised in a household where that was the common theme, expect to work twice as hard to be recognized and to be rewarded. I started to understand that. Professionally, it was very easy to recognize it in my very first class in public health. Mm-hmm. My very first epidemiology professor, her name is Annette Rossignol, and she focused on poverty and low-income populations in her research. And she was also very wide in her research and her interest. And she was talking about the health and wellness of workers who harvested, farm workers who harvested oranges for, major manufacturers and producers of our consumption. And she talked about the inequality of services, that occupational health and wellness was not advocated for certain farm workers, who are so essential to our care and wellness. And she gave a compelling example about how they're not even appropriate compliance to regulations of number of toilets in work areas for women who are harvesting oranges for us. And because my consideration is around pregnancy and childbearing, I thought, how is it possible for people who are working to remain at work when pregnant? When if you've ever been pregnant, you realize you have to have facilities available to remain employed, or you're out of work for that period of your life. And that inequality was based on class and race. And ever since that first lesson in understanding the social determinants and how systems, how workplaces, how all things related to health are unequally distributed for the vulnerable by poverty or by race and ethnicity, I've known about. In the article I wrote, I talked about the air that we breathe. You know this. The food that we eat, food deserts, the wages that we qualify for because of the limitations of education. These are inequalities that have been baked into American history from its founding. And so there are structural racism and outcomes that are a direct result, an indirect result of a system of the founding of this country. And you see it every day, every way, when you look at the unequal distribution of the economic engines for mobility, and that's in education. I started talking about education in my life and in my journey because early on as an immigrant family, we understood the primacy of education in everything for health, for economic advancement. And they're also interconnected that in neighborhoods where I grew up, we saw people working 3 or 4 jobs with very little economic security or an opportunity to build wealth. You might remember David Williams, a professor in social and behavioral sciences, who talks quite eloquently about in America, for every dollar of wealth that a white person has in the US, an African American person has 8 cents.
Oh my God.
That is quite a disparity in wealth. And we know, we're aware of the income gap as well, right? That 74 cents on the dollar is what an African American makes compared to their white counterpart. You add that to the other financial injustices, the predatory lending, the vulnerability that Black and Brown individuals face when there is an economic crisis or in the crisis of a pandemic. All of these are just illustrations of the built-in structural inequality, structural racism that characterizes the statistics we see as the outputs for health disparities. Public health, though, was the beginning. To get back to your question, it was a list of stories about low-income Black and Brown workers who are essential for the supply chain of our food, who were not seen and are structurally ignored as a result of the way our work and food systems have been built.
That's an intense story. Thank you for sharing that. But I want to point out a phrase that you used, which was structural racism. And during this time of, we've got the pandemic, and now we have so many protests, so many people speaking out, including yourself. And I think there is something very seminal, this is a very important point in time when it takes the death of an African American person to get us out of our safe homes and in this state of pandemic, right? What our country is going through. There are some people who still feel very uncomfortable talking about racism. There is a sense that, I am not racist, or, how can I be party to this if I'm not a racist individual? And I think what I'd like to hear from you is maybe if you can explain to us what is racism when you talk about it, and structural racism.
Yeah.
Tell us what that is.
Yeah. First, racism. Racism, and I've been following the news. Merriam-Webster Dictionary just updated the definition, and I wish I had it in front of me, and I don't. But I think when we think about racism, it is a system, a way of behaving and doing. Either it's allocation of education, food security, delivery of healthcare services. It is those systems that are built to provide support for individuals, and where, on the basis of someone's race, and it's in the US, it's a physical appearance of being Black or brown. If the distribution, the delivery of services is dependent on someone's race, in a systematic way that disadvantages one race and privileges another, for me, that would be racism. Now, structural racism, it does not necessarily have to involve the act of being a racist. Structural racism privileges those where the system gives them higher levels of access to education, housing, food security. That is a result of a system or a set of processes in place that systematically disadvantages Black people in America. When the Brown versus Board of Education was passed, there was an active backlash against the legislation. And there were laws, and redlining is another example, that housing, where people would live, where people would get mortgages, are defined and based in ways to discourage desegregation. Those are systems put in place that are structurally denying a race of people, Black people, from participating in the normal economic life of the country. You don't have to be a racist to recognize structural racism. I think what this moment in time is doing for all of us is allowing some space for us to have a conversation and to use that word, racism, race, racist behavior. One does not have to have their knee on the neck of George Floyd or others to recognize and appreciate that the system of allocation of essential determinants of health and wellness are disproportionately distributed across populations. When COVID-19 outbreak started and we all rushed to provide testing, we didn't go to the low-income neighborhoods and start developing the testing there. The system in place did not take into consideration the structures that undergird our healthcare delivery system that is already in and of itself unequal. And so it was late in the state of Massachusetts. It was late before we got to Chelsea and setting up drive-through testing facilities. And think about how unfortunate that is because of the long-lasting economic inequalities and the fact that many Black and brown people have jobs that don't easily lend themselves to working remotely. Their risks were already higher because of the high proportion of low wage jobs that required, commuting to work and being at work and not engaging in the working remote intervention that we in public health were saying. Couple that with the fact that they are then less likely to be tested.
Mm-hmm.
This is a confluence of a structural bias, in part built on a history of slavery and the legacy of slavery that denies an appropriate equal distribution of opportunities for the kinds of employment and wage and facilities to have testing and early detection. So it's complicated, and I have been in conversation with other experts who say the message matters and the messenger matters. And we in public health, we know this, that we have to work doubly hard in making sure that the concepts that we know and recognize using the words that we typically use are not necessarily always accessible to the general population who needs to hear, understand, appreciate the messages that we bring to public health.
Everything you said is so true. And I think almost all communities across the US experience something similar. Certainly here in San Antonio, the first thing our health department did was, if you were going to be tested, there were certain requirements, right, that the CDC put forward, which was, well, you need a doctor's note. And we know that alone is a huge barrier for people who are uninsured, for people who may have lost their jobs, who is their doctor. And, if you have to pay so much more out of pocket, obviously that's a whole other barrier. And drive-through facilities, not everybody has a car. So we learned a lot, like you said, through this period. I wanted to ask you about the op-ed that you wrote around the time you wrote us this letter. Your op-ed came out with State Representative Sanchez, and I wanted to know, was that the first time you had really spoken out on racism in public health? And if so, what is different for you this time?
Yeah. It's not the first time that I spoke out about racism as a determinant of health outcome, but it was the first time that I was so deeply motivated by the pain and suffering personally, and just as a member of society. I think watching COVID-19 unfold the way it did, with Black and brown people having a higher proportion of mortality, and that the George Floyd event and the Christian Cooper event in Central Park, where they were startling. I mean, we're already all under stress because of the COVID pandemic. We're all working in an upside down world. We are seeing horrific statistics of death. 118,000 deaths now in the US because of COVID. And when you overlay the uncertainty, the stress, the anxiety, and you see now this blatant act of racial violence, it was, for me, a bridge too far, where I had to break out of the subtle scholarly conversation about social determinants of health and really give racism in its full weight of that word, and talk about, that this is emblematic, symptomatic of what we are seeing in these two pandemics. We are seeing the pandemic of COVID, and we are seeing the pandemic of structural, historical, legacy violence against Black and brown people. The moment really for me was feeling defeated as a public health scholar who spent 30 years trying to advance public health and education, in realizing that in the 1918 Spanish influenza, 100 years before, during Jim Crow period,
right.
Blacks who were suffering from the influenza, just as their white counterparts, were dismissed, were not supported. And I felt that 100 years fast forward, and we're seeing similar health statistics, similar racial differences. And I thought, it's been 100 years. What will it take? And it requires our thinking about a new and different normal where we speak out. Sometimes we have to bluntly. And so honestly, I will tell you, the experience made me angry. I was feeling pain about, this sense of here we are 100 years later, 400 years when you think about, the 1619, the way our people came to this country. And that pain, I think, motivated amplifying my voice even more than I would. And I'm an introvert. I'm an academic, but I realize I'm not going to be a part of the solution if I don't find another way to work and communicate. And that's for me personally, but it's also for all of our students, faculty, and staff in public health. We have to be engaged in a stronger, more assertive way of creating the knowledge and doing it as rigorously as possible. But we should use our voices more, and we should partner with public servants like yourself, and we should speak directly to your guests so that we democratize what we know and motivate the social and political will necessary to make the change. We can't have another 100 years of being unprepared for a pandemic or having the outcomes be disproportionately borne by poor people, Black and brown people. And don't get me started about the pandemic that's happening on the native, the Navajo Nation, or the incarcerated people whose livelihood, whose lives depend on our seeing them, recognizing their vulnerability, and serving them as well, irrespective of the crime that they have committed that landed them in prison. So I would say COVID for me activated me in ways that nothing else has, because it really shines a light on how much more we have to do. And that's where the article comes from. Jeffrey Sanchez, is a great friend. He's a lecturer at the School of Public Health. He was the chairman of the House Ways and Means Committee. When Jeffrey was a kid in Mission Hill, where we went to school, Jeffrey suffered racism at the hands of Harvard University police. The poor kids from across Huntington Ave, the Black and brown kids from Huntington Ave, were not welcomed on our campus. And look where we have come in a lifetime. And I'm so proud of my friend Jeffrey. I'm proud of you. I'm proud of where I've come. But we have so much more to do to lift up, our people and to break down the barriers. And I think if we're successful in doing this, everyone benefits. It's a healthier, more robust, more thriving society. So thank you for asking that question.
All your answers are wonderful, and thank you for speaking out the way you did. And you talked about trusted messengers earlier, and the truth is, people in the health field, people in the academic field, they're more trusted than someone like me, who, I consider myself a public servant, but some people will see me as a politician. And as much as I can speak out, it will work in some cases, but there's also a lot of skepticism around what elected officials say. So thank you for being inspirational and bold and doing what you do, because I think it keeps us motivated too. I have some questions about social determinants of health.
Mm-hmm.
This is going to be, in a perfect world, if you had the full federal budget at your disposal, which would be your first three social determinants?
All right. First, that's a great question. So let me first start with the federal budget. Because, let me just share some facts. You know this, but maybe your guests don't. That of all of the dollars the U.S. government spends on health in the U.S., only 2.5% of those dollars go to public health. Yeah, 2.5%. You know what that amounts to? That amounts to $274 per person per year invested in public health.
Oh my God. It's not
Public health, we all know now because we're living through COVID, is a primary driver for our economic and our social national security. But public health has been consistently, painfully underinvested for too long in this country. So I would say legislatively at a national level, we need to stand up and recognize the primacy of public health as an engine for our national security and our health and wellness of this country and economic security.
Sorry, before you go on to the other two social determinants, I think at this point it would be really great to explain the difference between public health and healthcare, because everyone hears, oh, we spend so much money on healthcare. So
yeah. So this is where social determinants is really important, because we also know, and there's a lot of research that shows that, the determinants of our health, about only 20% maximum, 10 to 20% of the drivers of our health are in the medical clinical space. The other 80 to 90% of what determines health and wellness is way upstream from the hospital. It's way upstream. It's where we live, the food we eat, the air we breathe. These are the social factors that drive our health and wellness, okay? Healthcare takes care of sick people. And we know in public health that taking care of sick people is not the way you want to go about promoting health and wellness. You want to be way upstream, supporting those factors that support wellness and health in the first place. Don't get me wrong. I mean, when I need a tertiary care hospital, I want that tertiary care hospital to be there. But what we have to do is balance the ratio of where we put our precious resources and where we put our human capital in supporting and promoting health and wellness. Think about how we can change the distribution of funds to provide physical activity, opportunities for physical activity, opportunities for healthy eating, opportunities for weight control and weight management before we have to worry about end-stage renal disease, provision of dialysis services, way downstream treatment for illness as opposed to investing in illness. Think about how hard it is for someone to get insurance coverage for, a physical activity coach who might actually help prevent, the downstream illnesses associated with severe obesity, diabetes, hypertension, and end-stage, organ damage. So social determinants of health takes a broader view of health and wellness. It takes the view of what are the environmental, lifestyle, policy issues levers that we can toggle that promote health and wellness on population scale. Okay? And if it's done right, it's a good combination of the sister disciplines of clinical medicine, and we all will need clinical medicine, but it balances the caring of illness with the health promotion, disease prevention opportunities that we have. You know, social determinants, when you think about substance use disorders, you know, if we handle substance use disorders in a way that's different from our criminal justice system managing it now by incarcerating, you know, addicted people, we could have a completely different dialogue about managing secondary prevention of the unraveling of the mental health and wellness of an individual, let alone their families. Public health is complicated. We have to work really hard in messaging these complex web of causation that drives health and wellness. And you know, a good friend of mine once said, public health needs a PR agent. And we really need a PR agent to describe what public health is, to describe why it's important, and how we benefit from the returns of investment in public health. When we are successful in public health, when the water is clean, it's not Flint, Michigan, right? When the air that we breathe, you know, we're not seeing high utilization rates of ER or missed school days because of asthma triggers. You know, we are successful because the kids are in school. The water, when we tell people to wash hands, think about the irony of the beginning of the outbreak when we're telling people to wash hands, wash hands, wash hands. And in Flint, Michigan, mothers are every day worried about the fact that they still don't have lead-free water.
Mm-hmm. And the long-term consequences. Yeah. Mm-hmm.
Yes, these are the factors that we think about in public health. They are all interrelated. They are drivers of the disparities that we see in, you know, respiratory diseases, cardiovascular diseases, obesity. Food deserts is a huge problem for many, many communities. And these are social determinants.
So I still want to give you your chance to give your top three. So
okay, so top three. First and foremost, we have to provide opportunities for education. Education is an economic driver and for social mobility, but education is also a driver that supports health and wellness. Literacy, health literacy is going to be important. So that's my top one, education. Access to preventive care, wellness care, and medical care when needed at a high level of quality that supports individual health, but is also compatible with improved population health outcomes, and is also efficiently provided at a good cost that is not the cost we're paying now. So, right, that's my second one, access to good quality healthcare. And then I think it has to be a community that has greens. I'm going to cheat and add a bunch in my third one. A community that is safe, where there's green space and opportunities for people to engage with the environment, for recreation, for physical activity, for rest, relaxation, and for connecting with individuals. If we have an environment that supports all of those, then I have cheated and I have given you several social determinants that fit within an environment.
Mm-hmm.
Does that sound reasonable?
It sounds like a place I would like to live. So yes, it does. It sounds wonderful. And we have, I know we're going to try to wrap up by 8 p.m. And I have two really interesting questions for you that have come in. And I'm glad you brought up a safe environment. You know, in this whole conversation that we're having about what does our police force do? What are they responsible for? Yeah. Somebody is asking us, how would you define safe? How would you define public safety?
Yeah, that's a really big question, and it's a very important question, and it's one that I've been thinking about and talking about with some of my public health colleagues. Public health and public safety, I think, go well together, right? Unfortunately, the pendulum has swung where the responsibility for public safety has become much more militarized. Our police departments, which traditionally have had the responsibility for public safety to protect and serve,
Right.
over time has become so militarized that they've forgotten that safety piece and have become definitely more aggressive on law enforcement piece, to the point where you see an aggregation of war incidents, in police forces. So, for example, my husband, who is from San Antonio, born and raised, told me the story that the LA school security department, the LA school policing unit, actually spent money on grenade launchers.
What?
Why would you need grenade launchers if you are the public safety hospital for LA schools? This is a question we are asking in our household. So, there has to be a separation between this policing the way it has evolved and the safety that I think would be more consistent with public health. And that's going to mean, providing support for individuals in need when there is a need. So, for example, when there is isolation or drunkenness, that there is social work, there is a compassionate delivery of care and service to mitigate the risk, the harm that would threaten the safety of the individual or their community, and to do so in a way that does not necessarily cause escalation of harm to the officers or to the community members. Mm-hmm. Safety means, I think, again, providing careful, thoughtful, coordinated messages about where the community level threats are and risks are, and enabling individuals to participate in taking down those risks and those threats. I think in the coming years, weeks and months, we're going to see our communities much more engaged in reimagining the role of policing. I've heard people say defund police. I think that is rhetoric that needs to be very thoughtfully, carefully reimagined in ways where we are reassigning, reapportioning, and supporting the safety experts, the social workers, community health workers, the psychologists who can help bring about safety and care to community members in need. And then I think we're going to reimagine and see how we train and prepare police officers to de-escalate situations, to de-escalate how you would manage a mentally ill person who is in public causing a disturbance. There is no excuse for not being attentive and thoughtful in trying to de-escalate those types of situations. So I think we're at the beginning of a period where we're going to, as a community, as a population, as a nation, reimagine how we do our policing and how we manage public safety issues. And if the pendulum could be swung back to supporting public health departments and putting the right tools and resources in place, we'll benefit from having prevention, and we'll benefit from having compassionate care, I think, effectively delivered. We'll also have better data. You and I know about data. Evidence-based decision-making requires evidence. We need to have better database systems so that we can test and learn, evaluate, and reposition what we do based on evidence, based on the impact that we want to have, and correct the gaps when we're not having that impact.
All right. I know I said only 2 more questions, but I'm going to cheat. I'd forgotten early in my script. I did have a question about your husband, Dean Williams. You've got to tell us, what high school did he go to?
He went to Sam Houston High School. Okay. My husband, his name is Aaron Todd Curtis, and he is a proud Texan. I will tell you, he is a graduate from 1977 class of Sam Houston. And I met him in college. And he, like all the other Texans that I know, whatever they got together, more than two of them, they would sing "The Stars at Night" or "Big and Bright" deep in the heart of Texas. And I'm telling you, I have been completely overtaken by you Texans with your pride and your song and your history and the bigness of Texas. And so when I got this invitation, I had to absolutely say yes. I'm a big fan. I'm a big fan of you, Councilwoman. I'm so proud of you. I love San Antonio. It's my husband's hometown. I spent the summer at UT Austin.
Oh, okay.
And Barbara Jordan, another proud, wonderful woman leader in Texas, is someone that I look up to and is a source of inspiration.
Oh, well, thank you for saying that. When my staff reached out to invite you, and I'll rat them out now. They did this unbeknownst to me. I said, "Oh, she'll never accept. She will never accept. Don't waste your time." And they said, "She said yes." It turns out her husband's from San Antonio. So thank you, Mr. Curtis, for your connection, and thank you for joining us. Okay.
I'm so proud of you. I'm so proud of you. You make the Harvard T.H. Chan School proud. You make me proud. It's wonderful to get to know you, and just keep up the great work. I am your fan.
Thank you. I would be remiss if I didn't say that we have other alums on the Facebook Live. I saw some of the names pop up. Michelle Lugalia Holland is on there. So thanks for watching. And this is I'm going to be respectful of your time. I know we started a little bit late, but I do have one question.
Sure.
It is from Dr. Lisa Ochoa, who's a vascular surgeon and someone I admire very much in the community. She was with a wonderful surgery group, but realized that the problems are really in another part of town where, we have our own geographic issues here because of redlining. So she went and she opened her clinic there and took a huge risk, and she's doing fantastic. So Dr. Lisa Ochoa asks, how can other healthcare professionals work with you to acknowledge racism in public health?
Yeah.
How do we come together for this common goal?
I think this is a great story, and I love that question. And let's commit to do something together. Let's commit to share our stories. Let's commit to ask these questions. And I'm going to tell you, I'm very interested. That this question comes from a vascular surgeon. Because one of the things that I've been thinking about for quite some time now is the importance of rural health. We have a lot of challenges with inadequate services and support for communities in rural areas where clinics and hospitals are closing, and COVID is making that even accelerate. I read an incredible article in ProPublica about the high rates of amputations among diabetics.
That's our problem here.
Yes. And there is this heroic story of an African-born, African-American vascular surgeon who works in the Mississippi Delta area in promoting the protection of diabetics' limbs, increasing the rates of amputations by committing his career to being a vascular surgeon in a community that needs it the most.
Yeah.
His story has changed the way I think about the face of rural health and the importance of our coming together and working collectively to support each other. I would love to continue the conversation because even in the access to limb-saving surgery is based on historical, racial, poverty level indicators that we have to work to suppress. The story I read broke my heart, and it's amazing that this question is being brought forward. We can do this, and we have to think about social justice, access to quality health care, access to education, so that There is an opportunity for economic development, but there's also an opportunity for health literacy. If we got to a population suffering from diabetic retinopathy earlier, if they knew to come to clinic earlier, and if they had the quality care earlier, and if our Medicaid and Medicare policies were written to promote limb-serving surgery as opposed to amputation, we would have better outcomes at the individual level and at the population level. And I think we would have better value for the dollars we spend. So I don't have any specific direct answers, but I think if we can collectively work to solve these types of problems, we're going to start seeing benefits on scale. It's a great question, and I know I went on too long, but this is important.
Dean, we are respecting your time. As long as you want to talk, you will have an audience.
Thank you. Thank you. It's a great question. Let's commit to stay in touch on this, and I will help convene a conversation around this topic. I will do this.
Thank you. Thank you for that commitment. And actually, the councilwoman who represents the area where that clinic is, where the doctor's clinic is also watching this broadcast right now. So I know she will be willing to be a part of that with us. And that is exactly Dr. Ochoa's story. Is, you know, she wants to work herself out of a job. You know, that's not how she wants to make money. So. Well, I am supposed to give a couple of reminders to the audience at this time, and that is Nowcast SA is sharing this, and they will be archiving it on their website. They're a local outlet here, and if you liked what you saw, or if you thought it was interesting and thought-provoking, we ask you to share this with your network so that we can further this conversation about public health, about public safety, and to really get us talking about racism. And once we can see it, then we can solve it. I believe if we're not willing to see it, we can't make progress. So, Dean, infinite thanks for joining us. It has been an absolute pleasure hearing and learning from you. You are truly an inspiration for us.
Thank you, Councilwoman. Be well, and thanks again. Bye-bye.